Okay, I think we're ready to make a start. So welcome everybody to this afternoon's session. We're talking about how to make sense of an emerging COVID-19 evidence base. This is part of the Festival of Learning for NHS and the local government, looking at some of the challenges around making decisions in the complex environment of health and care, and thinking about how we might better use analysis and evidence and data to help inform some of those decisions. And we've got an excellent panel lined up for you this afternoon. So I'm really looking forward to this discussion. And this session came about, just as a bit of background, we've been doing some work over the summer to look at evidence in relation to COVID-19 to inform the recovery planning process. And I guess we just became aware of all the sort of challenges that we normally have around using evidence. So, you know, the huge amount of volume and the variable quality and the diversity of sources of evidence. And we just realised how amplified those have been with the COVID pandemic. And so we were interested to explore some of those challenges in more detail. And this afternoon, we've got a panel lined up for you to just consider the evidence base from different perspectives, really. And we've got 3 people lined up to share some of their perspectives and insights and reflections around some of those challenges, but also what that might mean for our ways of working and how we generate, use, find and apply evidence to inform our COVID response. So without further ado, I'll introduce everybody. So I'm Alison Turner. I work at the Strategy Unit and I lead on evidence and knowledge, and also supporting the Decision Support Centre network, which is part of, sort of associated with the launch of this festival as well. And on our panel today, we have Dr. Jake Seward, who is a anaesthetics and critical care doctor from Queen Elizabeth Hospital in King's Lynn. We have Anna Jenkins from NHS England and NHS Improvement, and Hardeep Aden from Health Foundation. So I'll introduce each of them as we go through, and hopefully we will have some time for questions at the end as well. And also behind the scenes, we've got Janine working very hard to make sure all of this is running smoothly. And Janine will be keeping an eye on the chat box for us as well, and so feeding in any comments and questions. So just a few housekeeping things to note before we start. So we just ask that you keep your microphone muted during the session, just to cut down any background noise. Please take the opportunity to introduce yourselves in the chat box and say hello, tell us where you're joining from and what your role is, and also use the chat box to ask any questions, or if you're having any technical problems, do that and let us know as well. We encourage you to tweet during the session, using the hashtag Insight2020, and you can copy in the Strategy Unit as well. We'd love to hear your feedback and thoughts and reflections, so please do that if you're a Twitter user. And also we are recording the session, so we will share the link with you some point afterwards, probably a week or so afterwards. So I think we'll probably make a start. So I'll just start with Jake. And we're really pleased to have Jake on the call today, because we had a conversation a while ago about long COVID. And so having contracted probable COVID back in March, Jake has been doing an amazing job of connecting with various different people, despite being very unwell and probably going through quite a stressful period, of connecting with people to get long COVID recognised as a syndrome, but also to start to advocate for a sort of coordinated, systematic response to research and practice into helping long COVID patients. And Jake's going to share with us some of his reflections and insights from that period. So I just hand over to you, Jake.
Thanks very much, and it's good to be with you this afternoon. It's a very interesting topic and quite a broad topic to discuss the evidence base around COVID-19. So what I wanted to do was focus on a bit of a blend of my personal experience since March with symptoms of COVID, and how I've seen the story of the long-term complications of COVID develop over the last few months, as an example of some of the challenges in general around emerging evidence in the context of COVID. So I'm not an academic, I'm a clinician, but obviously I use evidence in my practice anyway. So at the beginning of March, I was expecting to sort of have to adapt to new evidence emerging from COVID, but in the context of intensive care. But it turned out that when I got very unwell towards the end of March, it started to, my focus in the pandemic changed to my experience of my illness. And I had very frightening symptoms of shortness of breath, chest pain, difficulty thinking clearly, ongoing temperatures. And this has really lasted for months and months. I'm about 7 months in now, and I'm much better than I was, but I'm still not quite right. So I've taken an interest in the long-term complications of COVID, basically. And I think the story of the long-term complications of COVID follows a pattern that we've seen in other aspects of our evidence to do with COVID as well. The fact that in February and March, our initial thoughts on the disease were that it would be a respiratory illness, and we've had emerging evidence that it's a multi-system illness. The early thoughts that this was spread by droplets, whereas now there's increasing evidence that this may well be transmitted by aerosols. For example, emerging evidence that the role of transmission in children and so on. So I think the story of the long-term complications of COVID probably follows a similar pattern to some of the other fields of evidence that we have to do with COVID. So there's a few characteristics of the problem which I think struck me as I was thinking about this talk. One is that it's a field that's surrounded with uncertainty and emerging evidence. And so how do we manage when we have uncertainty and a rapidly growing pool of evidence? Very early on, there was pretty much no evidence about this. This was, I found out that I wasn't the only person having symptoms by reading a blog by Paul Garner in the BMJ. It was initially very anecdotal, and it came from the media and newspaper articles, for example. Slowly, the evidence base has strengthened over time through, for example, the King's College Zoe Symptom Tracker app that shows that about 2 to 3% of people still have symptoms after 3 months. But again, there's limitations of that type of study, and it's taken 7 months or so for that data to come out. So there's clues here, but it's kind of a delicate area, and the strength of the evidence is not that which we would usually be comfortable to make decisions on. I also think there's a bit of a phenomenon that you can be overwhelmed with evidence, and that when you go to see a clinician, so for example, lots of people who've been struggling with the ongoing symptoms of COVID, with breathlessness, chest pain, many people, I think, have had, when you first learn something, we were told that the symptoms would be shortness of breath, cough, temperature, and then all of a sudden the crisis and the management of the patients in the heat of the pandemic occurred. I think it's been difficult for people to update their cognitive picture of the evidence as they go along because of the circumstances. I think it's the nature of the pandemic. It's difficult to be able to assimilate all of that evidence as you go along. Something else that struck me about the situation was that an absence of evidence is not the same as evidence that the problem doesn't exist. And I think that's something else that's very prescient and very poignant about evidence in this sort of area. We have to acknowledge that where we don't have evidence that people can be reinfected, for example, that was the case for months. People were saying, oh, well, you know, there's no evidence that that can happen. And now there is emerging evidence that that can happen. So it's not that, it's not a criticism, it's the nature of emerging evidence. But I think anyone who's using the evidence has to be open-minded and comfortable to embrace the uncertainty of the situation. I think there was also a sense, from my perspective anyway, that wherever I turned in the early days, there was a feeling amongst people that somebody else would be looking into this, that the responsibility for collating the evidence in this area would lay with somebody else. And actually it didn't seem to be the case. So for example, what I mean by that is when I was struggling to recover at about 5 weeks in, I contacted Public Health England to see whether or not there was any systematic approach to following up patients, and it turned out that there wasn't. I wondered whether or not there would be a pattern recognition by referrals to tertiary centres, for example, and clinicians noticing a pattern of people not recovering, and that didn't seem to be the case either, because acute services were so overwhelmed. I also wondered whether or not occupational health departments would be in a good position looking after healthcare workers who may have had the disease and had access to testing early on, to develop a picture that people weren't recovering. And again, it seemed that there was little linkage between the occupational health departments to be able to get that message out. So I think there were a few mechanisms that you would perhaps have expected to detect that people were not recovering that seemed to fail early on. And that also might have just been my perception as somebody who was really struggling with the symptoms. It may have been that these mechanisms were working behind the scenes. But I think it's interesting to consider the story of how these symptoms have now been raised to a very prominent position in like media articles, and being acknowledged by the Health Secretary, the NHS commissioning clinic. So it's moved a long way in 7 months, but I think that initially it felt as though the system and the structures were not equipped to capture this evidence. So moving forwards, I think the lessons that I would take away from my experience with this, but which I think can be applied to other areas of the evidence base, is that patient involvement can be very helpful. So early on, some patients performed their own research into some of the symptoms, and there were a few characteristics that they noticed, such as a relapsing, remitting pattern of the symptoms, an emergence of new symptoms down the line. And those were kind of little red flag things to me, that this might not be a traditional rehabilitation problem, but there might be something going on about the mechanism of this illness that we don't fully understand. And there have been immunologists, the British Society of Immunologists have released a briefing note about possible mechanisms of the illness. A professor of immunology at Yale, Professor Iwasaki, has hypothesized that there might be either an autoimmune mechanism behind these symptoms, and that seems to be, there's recent papers that have shown that certain people who've had COVID have made autoantibodies, so that is an area of interest. And the possibility of things like reinfection or persisting low-level viral persistence, which would fit in more consistently with the nature of the symptoms, rather than us trying to fit what we expected to see from our knowledge of other diseases, which is where you would expect the people to be most impaired. Would likely be those who have been on ITU and so on, which, those people are impaired, but there's a lot of people that were not admitted to hospitals, who are managed in the community, who are still really left quite debilitated 7 months on. We still don't know how many people that affects. We've got kind of data from the King's College app, but as I said, the methodology on that is quite limited. So the other thought that I had going forwards is that what gets measured seems to get managed, and we can see that with the data that the government puts on its dashboard, that you have ventilated beds occupied, hospital admissions, deaths, positive tests, but no data on recovery or data on people still off work, for example. So I wonder if there's an argument that some of this data needs to be collected centrally, especially for a situation like COVID where you have a novel virus. So whether or not you could ask test and trace to phone people 4 weeks after a positive test, 12 weeks after a positive test, and ask them, are you recovered? Are you back at work? Do you still have symptoms? Most importantly, I think it's important that we carry on doing what we have done, which is to acknowledge uncertainty. So we have to keep an open mind about these symptoms and the long-term effects. Keep asking the questions, keep trying to count how many people are affected, characterize the illness properly, try to look for what the underlying mechanisms are, and pursue research that would, elucidate that and potentially help with treatments. I wonder whether if it does turn out to be either an autoimmune process or an immune process of some sort, whether or not a similar type of study to the recovery trial could be employed for patients in the community. But we still don't know whether or not patients in the community would benefit from prednisolone, for example. Would they benefit from antiplatelets? Would they benefit from anticoagulation? So I think the level of community morbidity needs to be really looked at in the evidence too. And then finally, sort of how you rapidly communicate emerging evidence, so such as the papers that have now emerged, where it looks like a German paper that looked at 100 patients who'd had a cardiac MRIs after a positive COVID test. 78% had evidence of myocarditis. So that's, and 2/3 of that 100 were never hospitalized. So that's emerging evidence. The CoverScan trial in a preprint paper looked at people who were still having ongoing symptoms at 4 months. So you can't take that as a representation of the whole population, but amongst the population that are still having symptoms at 4 months, even in a low risk population with no risk factors and an average age in their 40s, 70% of the individuals that were scanned had evidence of at least one organ injury at 4 months. So that's pretty profound, pretty significant, but that needs to be linked up with bigger picture data on how many people are still having symptoms at 4 months, because this could be a drop in the ocean, or we may find that we have a huge number of people in the community who are really significantly impaired. So how do we get that evidence out quickly? I wondered whether or not there was any lessons to be learned from what the ITU community did in the early days of the pandemic, where certainly high volume intensive cares had regular video meetings and disseminated their findings. I wondered whether or not any early trendsetters and post-COVID clinics like the clinics at UCLH, and I believe there are some others amongst the country already, may be able to release some of their common findings to GPs, A&E departments, other post-COVID clinics in a format that might not be peer-reviewed journals for the purposes of saving time, and then subsequently publish that down the line. And I also think the NICE rapid guidelines that are coming out shortly are very welcome, and I hope that they are also designed in such a way that they acknowledge uncertainty but are able to accommodate future evidence as it emerges. And that's about it from me. Thank you.
That's great. Thank you so much, Jake. That was really interesting. And I think it's really, really interesting to reflect on, like you say, the emerging findings and how we weave that in. And I was particularly liked your mention of how difficult it is for us to all update our cognitive pictures, and I think that's really important. How do we assimilate these emerging findings? And there's still so many uncertainties. So hopefully we'll have a chance to explore that a little bit more with the Q&A towards the end of the session today. So I'm just going to move on now to Anna and invite Anna to share some reflections with us. So Anna joined us from NHS England and NHS Improvement, and has been involved in the recovery response up in the northwest of England, and previously I think has been involved with the Getting It Right First Time programme. So Anna's going to share some of her reflections on restoring elective activity. Over to you,
Thanks,
Anna.
Alison. That was great. Yeah, so I wanted to talk a little around the work I've been doing in supporting the restoration of elective services up in the northwest, and that has largely been in relation to trauma and orthopaedic work. So this first chart, I plagiarised this from a workshop, a lessons learned workshop that I attended earlier in the summer, and I just thought it was a really interesting way to think about how we have reacted to change in the context of COVID. I think many of you will recognise that change curve on the left there. It's a popular model that's used to understand changes of personal transition and organisational change, and it really helps us think about how people react to change. But when COVID came along, it turned that model on its head, and certainly in the context of digital, you know, that change trajectory, it went out the window. There was a real sense of urgency, a recognition that we needed to act differently and quickly. And as I say, nowhere was that more true than in the adoption of digital. We sort of went remote and virtual overnight. It was quite incredible to see how quickly that technology was adopted and worked for the most part. So I thought it was really interesting. I'm sure that trajectory, that change in how we react to change applied to the different aspects of the health service as well, in terms of our decision making and how we adopt different practices in the face of COVID. And I'll talk a little bit more about that as we go through. But we're in a different place now. So we're 8 months into the pandemic. We know a little bit more about the virus, and we know a bit more about the changes and the effectiveness of the changes that were implemented, where they were effective and where they were less so effective. And I think health professionals generally are not reacting in that COVID curve change way quite as much as they perhaps were at the beginning. And I think there's a real sense that within the health service we were looking in different ways and perhaps in different places for that direction and evidence to inform behaviours as we still confront challenges with the pandemic. So in terms of restoring elective services, then NHS leaders too realised that the health service cannot be so focused on COVID to the detriment of other conditions and other health needs of the population. And so in the summer, most of you I'm sure are aware, this letter came out from NHS England around the phase 3 and really encouraged trusts to start thinking about how we could restore services and set some really ambitious targets around what trusts should be aiming for in terms of restoring that. I pulled a few quotes from that letter there around, you know, looking at restoring 80% of last year's overnight electives for outpatient and day case, rising to 90% in October. And in terms of their first appointments and attendances, follow-ups, face-to-face or virtual, looking at restoring 100% of those from September through the balance of the year. So there's some real ambitious targets, but that was not ignoring the fact that there are plenty of challenges lying in getting services back up and running to start with, having been completely halted, and then maintaining them as this second wave of COVID sort of hit the NHS. So what are the challenges in restoring activity? Well, there are a lot, and I've just plucked out a few here. To name the most obvious, COVID is still here. There is that need to manage the risk, to fully inform patients that, you know, in addition to the usual risks that may be associated with their treatments and procedures that they may have when they come into hospital, that there is the very real risk of transmission of COVID. In terms of getting services back up to speed, most trusts, if not all trusts, are are dealing with, are challenged by reduced capacity as a result of some of the practices that have been introduced as a result of COVID, be that, you know, spacing, social distancing in the waiting areas, meaning only so many people can come on what time. I mean, in theatre, infection prevention controls, really ramping those up, meaning they have to leave extra time between sessions in theatre so that there's time for a deep clean and for the laminate flow for the air turnaround. So there's all these things to think about. Theatre staffing is also a huge issue at the minute, and that's not just staff being off ill with COVID, particularly with the reopening of the schools. Lots of people are absent because their child is having to isolate, and they are having to stay at home because of that and to isolate with them. So there's a real struggle in terms of staffing. So with the best will in the world, they're up against all of these issues. Then there's the huge issue around how to prioritise patients. There was that harm priority matrix that was published with the Royal College of Surgeons, and they know that trusts are having to go through all systems rather through all their lists and categorise patients in terms of their priority. And there are some real sort of ethical conundrums that come up with that as well. You know, how do we understand, how do we make sense, how do we prioritise one patient over another? How do we, you know, how do we do that? And then in terms of in the context of trauma and orthopaedics especially, you may have a workforce that are ready to operate, and I've heard a lot of orthopaedic surgeons saying they're there and they're only doing a couple of cases a day, and certainly in the Northwest they're not doing any elective operating in many trusts because they've come up against wave 2 of the pandemic and they've got COVID patients coming into their ring-fence wards, so that's put a halt to their operating, their elective operating. So there are all these issues that they're having to battle with and to try and address in the best way. But I just wanted to draw out an example that I thought was really interesting in terms of how, professionals are perhaps behaving and looking in different ways and different places for evidence to inform their clinical behaviours and decisions. So we know that in May this year, NICE produced some guidance. Excuse me. It's the problem of working from home with a 6-month-old puppy. I'll just take myself in here away from the noise. So in May of this year, we know that NICE put out some guidance around patients having to isolate in the 14 days before they come into a hospital for a planned procedure. This was later revised in July, and they suggested that all patients receiving a planned procedure should be tested and then isolate for 3 days. But I thought it was a really interesting observation within the trauma and orthopaedic network I've been supporting as part of my role. There was discussion amongst the clinicians about views on this, the revision of the guidance, and they all felt slightly uncomfortable with this suggestion that it should be reduced. And I think there was a few things at play there. At that point in time, and still so now, the R rate was thought to be higher in the Northwest than in other parts of the country. And they came to a consensus within that group that they actually were going to continue to observe and use the original guidance that was published around the isolating. They felt more comfortable. And I just thought that was really interesting that they didn't just accept the guidance that had come down from NICE. There was a real sort of sense of professional camaraderie. I mean, they were reaffirming each other's and their own beliefs in the best course of action, and sort of reassessing the guidance and evidence that had come out alongside the revised guidance. So I thought that was really interesting. And so there are lots of other examples within this particular network that I've seen where they've used that way, that professional network and that professional camaraderie of facilitating their decision making, and that's been around things like pathways, around theatres infection prevention practices, around poor patients, video consultations, patient initiated follow-ups, patient consent processes, and I got the sense that, you know, for a lot of these things, it was new to them in this context. there wasn't necessarily a policy or guidance for all of these things, but there was a colleague in another trust who perhaps was doing video consultations before, you know, they could give them a call and say, hey, how's it working for this particular patient cohort? Does it work well? Who does it not work so well for? So it was really interesting to see that behaviour and see that a lot more professional collaboration than I've seen before now. So that made me think about what the factors influencing clinical behaviours and current decision making are. And again, I think there are lots, probably too many to discuss today, but I think the biggest is that there are still so many unknowns about COVID. It's such a new virus. There's so much more we need to learn about it, and the data can't tell us everything at this stage. There's also the geographical variation. You know, the guidance that came down from NICE, it wasn't geographically specific, it was national guidance, but we know actually that things are happening differently at this point in time in different parts of the country. Guidelines are changing quickly as well. Does that create a degree of uncertainty? So in May, there was, you know, NICE was putting out guidance saying isolate for 14 days, and it was revised a couple of months later. I think, as you know, clinicians see that and think, do we need to reassess here? Do we need to pause? Do we need to talk to our colleagues and get their views? And that's what I saw in play in that network. And there's also acknowledgement of errors that were made early in the pandemic, and there were some. There were inevitably going to be some, wasn't there? Just thinking off the top of my head around the, you know, quick discharge of elderly patients back into care homes. If we could do it all again, we wouldn't do that now, would we? And also the fact that healthcare professionals are just as vulnerable as patients to COVID. You know, when they're assessing the risk to their patient every day going into work, they ought to be assessing the risks of themselves. It's a very, very real risk. Nobody's immune to it. And I think that does prompt health professionals to reassess the evidence and also brings that additional perspective to it. Thank you. Sorry about the dog's interruption.
That's great. Thank you so much, Anna. That was really useful, really interesting to hear your reflections of how it's been in from sort of service delivery perspective. And it was really interesting. I hadn't picked up about the changes in the NICE guidance. So that was quite a nice illustration of how things changed so quickly. So I'm going to hand over now to Hardeep, just to keep us going, and then we'll hopefully have some time for questions. So Hardeep joins us from the Health Foundation as a research manager. And has a history of working with inequalities through the Equality and Human Rights Commission, also working with British Red Cross and Scope. And his role in the Health Foundation is around research and working with the Healthy Lives Directorate to promote public health issues. So I'll hand over to you, Hardeep. Okay.
Thank you very much. I'm just going to share my screen. Hopefully that's come up. So yeah, I'm going to speak for about 10 to 15 minutes, and Alison, if it looks like I'm running slightly over, do interrupt me. Great, so I'll quickly introduce the Health Foundation, and then there are 4 areas of our work I'd like to talk to you guys today about. So one is our COVID-19 research program, which some of you may already be aware of. The next is the work we're doing around a longer term research agenda for the UK. After that, I'd like to talk about our impact inquiry, which has just launched, and then an initiative I'm working on, which is called our inclusion panel. So very briefly, I'll just talk to you a little bit about the Health Foundation. So the Health Foundation is an independent charity committed to bringing about better health and healthcare for people in the UK. We connect what works on the ground with effective policy making and vice versa. And ordinarily, we're a grant-making organisation, and we've been doing that throughout the last 6 months or so as well. But a lot of the processes and things we do have changed, as they have for a lot of people under COVID-19, and the way we spend and where we spend our money too. So, as I said, a lot of our money goes onto grants or research commissions. This year, some of our money has actually gone directly to charities, which we think are at risk of disappearing without the funding that they would ordinarily receive from government. So we have actually given some of our money to charity this year. And all of us have been working remotely like a lot of other people, so we've been grappling with that as well. But a lot of our staff have, in addition to their work for the Health Foundation, have gone off to do volunteering for the local communities, the local government, wherever they can be most helpful. And also some of our staff have been seconded to the NHS and other organisations as well. So we've done as much as we can, practically speaking, to support the response to COVID-19. And so let me talk to you about some of the grants we've been giving, firstly through the COVID-19 research programme. Now, the COVID-19 research programme was launched in June, and the research programme was designed to understand the impact of COVID-19 on two distinct areas, which align with our existing strategic priorities. One was around health and social care service delivery and how that's changed in light of COVID-19. And the other, which is the one I've been focusing on, is the impact of COVID-19 on health inequalities and the wider determinants of health. Now, we're aware that there are other grant programs going on at the moment as well. The various research councils have given lots of money to COVID-19 research, as have organisations such as Wellcome Trust. So our contribution in this space is small, if you look at the overall picture, but I hope no less important. And we're trying to fund research that complements what's already being funded, as well as research that's quite novel, and maybe research that is possibly too innovative or risky to be funded by other organisations. Now, the COVID-19 research programme has come to a close now, and we've invited projects to apply for funding of between £100,000 and £200,000. So it's not a huge amount, as I said before, for a duration of up to 12 months. But what we really want to make sure is that we're funding highly applied research that has direct relevance to policy and practice, which is at the heart of everything we do at the Health Foundation. And we've really welcomed applications from multidisciplinary teams. And I just want to highlight, pick up on a couple of things as well. So Anna mentioned remote consultations or video consultations. We've seen a lot of applications in that area. And I can't reveal which awards we're funding until next week, but I think something like a fifth or a quarter of the applications we received were in that area. And we're really keen to make sure that we learn not only what went wrong during the pandemic, but what went right. So lots of people have changed the way they deliver services, or in terms of health and social care, but also looking at the impact of COVID-19 in terms of health inequalities. And we're really keen to make sure that we take best practice or things that have worked well over the last 7 or 8 months, as well as learn from the things that haven't, and make sure we feed that back into policy and practice. And just picking up on what Jake was saying earlier, we don't want to wait until 12 months are over and then make sure the findings go out. We want to drip feed those to the relevant stakeholders, policymakers, people working at the front line throughout the course of the 12 months, so that people have those findings to hand. And we're not waiting for journal articles, as Jake said, before people are able to use those. But at the same time, we do want to make sure that our research is robust. And the other thing I just want to pick up on is that we had a really great geographic spread as well in terms of where the applications were coming from, and hopefully that will be reflected in the final pool that we fund. So next I want to talk very briefly about the long-term research agenda that we're working on. This isn't an area that I'm working on directly, but if people are interested in finding out more about it, I'm happy to put you in touch with the relevant people. Essentially, given that COVID-19 has laid bare the inequalities, existing tensions and inequalities, not just in the UK, but more widely, we feel that we have a real opportunity here to convene a multidisciplinary or transdisciplinary cross-sector response to developing the UK's future research agenda. And so the work we're doing around the long-term research agenda will include a wide spectrum of voices in the debate around the future of the UK's research agenda in this area. We're really keen to make sure that we learn from national as well as international COVID-19 experiences, and I think that's really important going forward. And we want to start laying the groundwork for ongoing conversations with stakeholders domestically as well as internationally as part of this work too. So we're working with Ipsos Mori on scoping this engagement program. I've just put up the 5 work packages that Ipsos Mori are going to be working on over the next 8 or 9 months. I won't go through them in detail, but I'll just leave those up there for a minute so that you can have a quick look. And like I said, I'm happy to put you in touch with people leading on the long-term research agenda work at the Health Foundation if you'd like to find out more about that. But just to say that this will complement the work that we're doing as part of the COVID-19 research program, which is shorter term and much more focused on the UK experience. This is about this is broader than the UK experience, but also, as I said, looking to the future. Thirdly, I'd like to talk to you about our COVID-19 impact inquiry. And even before the COVID-19 pandemic hit, there were already signs that the health of the people in the UK was falling behind comparable countries. We funded the 10-year follow-up to the Marmot Review, which was launched earlier in the year, and that laid those issues bare. And so we were thinking about health inequalities and health as an asset before the COVID-19 pandemic hit. And so bearing that in mind and considering what's been happening over the course of this year, we've launched a time-limited UK-wide inquiry to consider how people's experience of the pandemic was influenced by their health and existing inequalities, and the likely impact of actions taken in response to the pandemic on people's health and health inequalities now and in the future. So what is the inquiry going to do? Well, it's gathering evidence from a range of sources to consider people's experiences of the pandemic and, like I said, how they were influenced by existing health inequalities and people's existing health conditions. And we really want to make sure that we highlight implications for government decision-making and the investment we need to ensure that everyone can enjoy the same opportunities for good health and well-being. We're mindful that there have been calls for a government inquiry or inquiries around COVID-19 and the response to COVID-19. Given that nothing has been forthcoming so far, we're pressing ahead with our inquiry, but we want to make sure that it feeds into any inquiries that the government carries out too, which is why we're pressing ahead with this and hoping to be able to share findings from the inquiry in summer 2021. And we have an in-house secretariat at the foundation, which we've recently recruited to help carry out the work, and they'll be guided and informed by an expert advisory panel. You can find out more information about our inquiry on our website, and again, do get in touch with me if you'd like to find out more about that work. And lastly, I'd like to talk to you about our inclusion panel, which is a piece of work I'm leading on and I'm really excited about. And the idea for the inclusion panel has been knocking around for a little while, but I think COVID-19 has accelerated the pace at which we brought it forward. And the inclusion panel at the moment is acting as a reference group for teams across the foundation to support the development of research programs and analysis, initially looking at the health inequalities revealed or made worse by COVID-19, but that may change over the course of the next year. Now, the inclusion panel comprises 20 to 30 members at the moment from across the UK, with a mix of professional and lived experiences, coming from a range of different communities to be able to talk about the challenges they're facing. And we're really excited about this panel because we've seen other advisory groups or panels or boards where you have people with a specific health condition or coming from a specific community or defined by a particular protected characteristic. Our panel is, like I said, involves a mix of people. And we're really keen to make sure that we listen to people and they're really take into account their lived experience as we develop our work on COVID-19. And so that will involve not just looking at our COVID-19 research program, but any new research we start from the planning stage all the way through to dissemination. We want to make sure that we're learning from our members who are going to provide advice and guidance to us, and to challenge our approaches and assumptions we're making, and also to highlight areas that we're not currently thinking about that they think we should be exploring as part of our work. And so we're really excited about this inclusion panel. We've not done anything like it before. We're bound to experience challenges in getting such a diverse group of people together and being able to make sure we meaningfully act on what they're telling us. But I think there's so much value from this initiative. I think it will strengthen our understanding of different forms of inequality, hopefully enabling us to make a more meaningful contribution in this space. And also the Health Foundation is committed to diversity and inclusion. And I think this is one of the ways we're making good on that promise. And as I said before, we'll have a range of people on, we already have a range of people on the inclusion panel. And we're really keen to make sure that we hear from marginalized and excluded voices. And I think we've seen over the last 6 months, well, 8 months now, I guess, that COVID-19 is affecting people from particular communities more so than others. And what we're not seeing enough of is, or hearing enough of, is the voices of those people in the debate around COVID-19, the impact it's having, and why specific communities are affected more than others. And this is one of the ways in which we're trying to redress the balance. And we think it will improve the quality and impact of the research we undertake and fund between now and the end of 2021, which is when the pilot phase for the inclusion panel will come to an end. And I'd just like to say that if, depending on how that goes, we will hopefully fund the inclusion panel as an ongoing resource beyond December 2021. And hopefully increase its size as well and potentially have sub-panels. But all of these approaches we're testing as we go along, we're experimenting with it, and we'll hopefully come up with an approach that works for the Health Foundation over the course of the next 12 to 13 months. So that's it from me. Do stay in touch with us through our email newsletter and follow us on Twitter or Facebook or LinkedIn if you prefer. And I'll hand back over to Alison, I think.
Brilliant. Thank you so much. That's been really, really interesting. And I think it's quite nice to see how some of those themes that we've explored with Jake and Anna, you've picked up in terms of that balance of timeliness and rigor and inclusion. And we saw particularly from Jake's talk how important the patient narrative has been in relation to COVID. So that felt like a really nice, nice sort of conclusion to some of the talks. So I think I'll just ask Jalene if she can check if there's any questions in the chat box, but I'm going to probably be slightly cheeky and jump in with a question.
There are no questions in the chat box. There's lots of positive comments and thanks for sharing resources, but there's no actual questions.
Oh, okay. Oh, in that case, I can take advantage and jump in with one of mine. I guess really, I'd just be interested, and I think you've all sort of hinted at this, but I'd just be interested in each of you sharing your thoughts on really what might we need to do differently from this point forward in terms of how we generate, use and apply evidence, and I guess where you perhaps might see the most important gaps in the sort of short term. So shall I just come to you in turn, and shall I start with you, Jake?
Yeah, I think it's probably, I'm biased, but I think we need to really look at what the long-term effects of COVID-19 are. And I think that involves counting it. I think that involves sort of the epidemiological evidence, and that might well be better collected centrally by whatever Public Health England or public health body across the UK comes in. So whether or not that's part of test and trace, whether or not it's done in some other way, but I think we need to start including that in the data that is published on the COVID-19 government dashboard, along with deaths and positive cases, because other countries do record their recovery data, and increasingly, as the evidence comes out that there is organ injury in people having ongoing symptoms, that proportion of patients becomes increasingly important. So I think to inform sort of public health measures, to inform policy, to inform commissioning of clinical services, to inform commissioning of ongoing research, to me, counting the size of the problem seems to be one of the key steps in deciding how big an issue this is. Because if it's not affecting that many people, it's still bad, but it's not terrible. But the law of large numbers is that if this is affecting 2% of people who've ever had an infection with the SARS-CoV-2 virus, I think it was even a few weeks back now, the World Health Organization estimated that there'd been 780 million infections globally. So it's a much bigger number than the laboratory confirmed numbers. So 2% of that starts to become a really significant burden on the economy, on the healthcare system. So counting it, but then, also just involving patients as you get evidence, working on the way that you disseminate that quickly, whether or not that's through NICE guidelines or whether or not it's through royal colleges, whether or not there's other ways of doing it which haven't occurred to me yet. And yes, basically, whilst we're waiting for that to happen, I think really important that we always include an almost an explicit acknowledgement of uncertainty, because it does feel to me in the general discussion that we've almost accepted that it's okay for large numbers of young people to have COVID because they don't die. And that seems to be a problematic conclusion to me, whilst we don't know what it does in the long term. So I agree it's a complicated area, but I think there needs to be this kind of explicit statement of we actually don't know what this does.
Sorry, I was muted. Anna, shall I come to you next? Thanks, Jake.
Sure, yeah. So I think I talked quite a lot about changes and practices that had had to change quickly, and how as a health service we reacted by implementing change really quickly. Not all of those changes had positive effects, and I think it's really important. Some did, of course, many did. Lots of the digital changes did have positive effects, but I think it's really important that as a system we capture and now go back and evaluate the impact of some of those changes with a proper evaluation framework, because there's lots of evidence to suggest that some of the changes actually had detrimental effects on not necessarily people with COVID, but other patient cohorts. So I think there needs to be a really systematic approach now to understanding whether the changes that were implemented as a indirect reaction to COVID should actually be maintained in the longer term. How we do that is quite another matter.
Brilliant, thank you. Yeah, we've had some sessions, I think, during the festival about evaluation, and so I'm sure we can signpost some of those, because I think there've been some useful discussions on that. Hardeep, shall I come to you finally?
Yeah, I'd just like to echo what Anna and Jake have said, and I agree with and that we need to have proper evaluation so we can take the best bits, best practices from the last 7 or 8 months, but also learn from what went wrong. And there are unintended consequences as well of some of the things that we've been doing or trying, and we need to be really honest about those and figure out how we can improve going forward. But from a health inequalities angle, I guess we still don't know why certain communities or groups or individuals are more affected by COVID-19 than others. We know that some groups are disproportionately being impacted, so people from ethnic minorities, so people with long-term health conditions, which overlaps heavily with older people. But there are other communities as well that we shouldn't overlook. Homeless people, how they've been experiencing the pandemic, young people. Just because they're less likely to get COVID-19 doesn't mean they haven't been disproportionately affected by lockdown and the restrictions that have been placed on them. So I think we really need some good quality research there. But one of the challenges we're seeing is getting hold of good quality data. And the ONS has done a fantastic job, I think, in terms of collecting and making data available to researchers. But we're having challenges getting hold of data from the NHS, for example, and linking data as well, which is really challenging. And that, issues around data access and linkage were happening before the pandemic. But I think this has laid bare just how much work we need to do in that area still. And especially when you need real-time data or as close to real-time data as you can get it. So those would be some of the challenges I think we should focus on. Also, just to say, I would like to see more co-production as well. And I know true co-production is really difficult to achieve, but I think we need to see a greater push towards that if we're serious about doing research on health inequalities.
That's brilliant. Thank you very much. I realise we've only got about 2 or 3 minutes left, so I'll probably stop. I don't think we had any more questions. So, but I thank you so much for your reflections and insights. I think it's been really interesting, and I think some recurring themes in terms of having a sort of more open approach towards evidence, I think, in terms of not just focusing on the very traditional empirical evidence, but pulling in the experiential evidence as well, and also the really important role of the patient narrative here, particularly in relation to the long COVID. And I think just some of those challenges in terms of how we balance that timeliness and rigor, how we deal with uncertainty, and how we keep adjusting that sort of mental picture, as well as some of the practicalities around, dealing with just the volume of information that's coming out. So thank you all so much for sharing your insights. Well, I'll just quickly share my screen to just let people know what's still to come up on the festival this week, if I can find it. Bear with me a second. Here we go. Okay, so this week, tomorrow, we have a discussion on introduction to decision quality. And then next week, we still have the final week to go. So you can see there's a whole range of sessions available there around the role of leadership for analysts, accessing data and code, population health management, and then we have a session with Al Mully, who does an awful lot of work around shared decision making, so that'll be really interesting. And then finally finishing next Friday the 13th, with a panel on decision making, and that will be the finale for the festival. So I think with the time available, just realizing that we've run out of time, and it would be lovely to carry on this discussion, but just thank you so much to our panelists for taking time out from very busy schedules to talk to us this afternoon and sharing insights. It's been really fascinating, so thank you so much. And thank you to everybody who's listened in. I hope you found it useful as well.